A Guide to Cardiac Vasoactive Drips, Part 4, Inotropes and Vasodilators. Welcome back, everyone. In the final installment of this 4-part series on vasoactive drips, we will move on from talking about vasoconstrictors and shift gears to take a close look at the use of inotropes and vasodilators. Inotropes can be used for heart failure, but recently they have been relegated to a limited role. I'll cover the pharmacology of these agents. Vasodilators are commonly used for malignant hypertension, and so I will go in depth to talk about their unique mechanisms of action, dosages, and side effects. Here's Part 4, Inotropes and Vasodilators. Let's start off by discussing a short case of a patient in hypertensive emergency. MH is a 68-year-old African-American male admitted to the emergency room. The patient has had severe headaches for the past 2 days, but no dizziness. His headache was not relieved by ibuprofen. MH has a long-standing history of chronic hypertension, poorly controlled due to non-adherence. He has not taken his metoprolol, amlodipine, or lisinopril for at least 5 days. He has some nausea and has not eaten today. He states occasional cocaine use. Vital signs show blood pressure of 210/140, a heart rate of 110, respiratory rate 32. Labs show a slightly elevated potassium level and serum creatinine. The assessment of this patient is the patient has hypertensive emergency. Hypertensive crisis is defined as all clinical presentations of an elevated blood pressure with a systolic blood pressure greater than 180 and a diastolic blood pressure greater than 120, with or without signs of end organ damage. Hypertensive emergency is one type of hypertensive crisis where there's a severe increase in blood pressure with an SBP greater than 180 and a diastolic blood pressure greater than 120, with signs of end organ damage. The other type of hypertensive crisis is called hypertensive urgency, where we have an elevated blood pressure with a systolic greater than 180 and a diastolic greater than 120, but without signs of end organ damage. In hypertensive emergency, end organ damage might affect the brain, eyes, heart, or kidneys. This elevated blood pressure is life-threatening and needs to be lowered to a safe level within a matter of minutes to hours. In contrast, in hypertensive urgency, patients can present with symptoms of headache, anxiety, pain, and upset stomach, which might lead to worsened hypertension. The therapeutic goal of hypertensive emergency is that the blood pressure should be reduced by 20 to 25% within the first hour, and then, if stable, to 160/100 to 110 millimeters of mercury within 2 to 6 hours. Here are some additional facts about hypertensive emergency. The most common cause for hypertensive emergency is a history of chronic hypertension. Hypertensive emergencies occur more often in African Americans than in Caucasians, among patients who have no primary care physician, and in those who do not adhere to treatment regimens. Withdrawal of certain blood pressure medications, specifically drugs acting on the sympathetic nervous system, can cause an abrupt increase in blood pressure, which is referred to as rebound hypertension. The abrupt cessation of high doses of clonidine or beta blockers can induce rebound hypertension. Hypertensive crisis can occur as a consequence of illicit drug use, such as cocaine, phencyclidine, sympathomimetic drugs, and amphetamine. So with the diagnosis of hypertensive emergency, the plan is to admit MH to the ICU for close monitoring of blood pressure. Nitroprusside drip is ordered to titrate per protocol to reduce blood pressure by 20 to 25% within the first hour. CBC, BMP, troponin, BNP, and urine analysis are also ordered. So now that MH is to start receiving nitroprusside drip, let's talk more about this drug. Nitroprusside's mechanism is that it's a direct nitric oxide mediated vascular smooth muscle relaxant. In order to better understand the mechanism of action of nitroprusside, let's spend a minute reviewing the nitric oxide pathway. The nitric oxide pathway begins with L-arginine being converted to nitric oxide via the nitric oxide synthetase enzyme. Nitric oxide then binds to and activates guanylate cyclase, which is an enzyme that stimulates conversion of cyclic GMP. Cyclic GMP then facilitates reuptake and sequestration of calcium, resulting in vascular smooth muscle relaxation and vasodilation. Now let's integrate nitroprusside into the nitric oxide pathway. The chemical structure of nitroprusside comprises a ferrous iron center complex with 5 cyanide moieties and a nitrosyl group, and is 44% cyanide by weight. Nitroprusside reacts with sulfhydryl groups on erythrocytes to release iron, cyanide, and nitric oxide. The nitric oxide activates guanyl cyclase to generate cyclic GMP. Cyclic GMP then facilitates calcium sequestration and removal from the cell, causing vascular smooth muscle relaxation and vasodilation. Nitroprusside is both an arterial and venous vasodilator. Its use is primarily for hypertensive emergencies, but it can also be used for severe heart failure. The dose ranges from 0.5 to 10 micrograms per kilogram per minute. It has a very rapid onset in seconds, very potent, short-acting, the duration of action about 1 to 3 minutes, and is easily titratable. Nurses can increase by 0.1 to 0.2 micrograms per kilogram per minute increments every 5 to 10 minutes. Blood pressure and hemodynamics must be monitored closely. Nitroprusside drips need to be protected from light using an amber bag. Let's continue the case discussion. Overnight, the patient required nitroprusside doses ranging from 1 to 3 mics per kilo per minute to maintain target blood pressure. MH is currently on 1.2 mics per kilo per minute. His BUN increased from 23 to 42 this morning, and serum creatinine increased from 1.4 to 2.0. Urine output was poor overnight. MH's estimated creatinine clearance this morning is approximately 33 mLs per minute. The patient's family noticed that MH is confused and doesn't recognize them. He seems more agitated than usual. When the clinical team is on daily rounds, the pharmacy student recommends switching to another IV vasodilator drip, such as a calcium channel blocker, for the hypertensive emergency. Question: what is the reason for this intervention? To answer this question, we need to talk about the toxicity of nitroprusside. As stated before, nitroprusside reacts with sulfhydryl groups on red blood cells to release nitric oxide, iron, and cyanide. Each molecule of nitroprusside releases 5 cyanide radicals, which reacts and binds with methemoglobin to produce cyanomethemoglobin. Extra free cyanide is converted by the liver to thiocyanate, which is then renally eliminated. As in our patient's case, where there is worsening renal function, buildup of thiocyanate can occur, causing thiocyanate toxicity. This is why switching to another agent was recommended. In thiocyanate toxicity, symptoms primarily involve the central nervous system, with weakness, anorexia, nausea, confusion, seizure, or coma. Thiocyanate toxicity risk is increased if the serum creatinine is elevated, or the nitroprusside dose is high, or therapy is prolonged. It's 100-fold less toxic than cyanide toxicity. One additional note about nitroprusside in the use of hemorrhagic stroke is that the drug dilates large capacitance vessels, including cerebral vessels that may increase cerebral blood volume, leading to an increase in intracranial pressure and a subsequent decrease in cerebral perfusion pressure. This is in contrast with calcium channel blockers, which may be beneficial to use in hemorrhagic stroke. The cost of nitroprusside is about $80 per 50 milligram vial. The attending physician agrees with the pharmacy student's recommendation and discontinues the nitroprusside and starts nicardipine drip. So let's move on and talk about the 2 calcium channel blockers that are available as IV drips in the treatment of hypertensive emergency, nicardipine and clevidipine. Nicardipine is a dihydropyridine calcium channel blocker. Let's first discuss how calcium is involved with vascular smooth muscle contraction. Calcium enters the cell via the calcium channel, then stimulates the sarcoplasmic reticulum to release intracellular calcium. The calcium then acts on actin and myosin filaments to produce smooth muscle vasoconstriction. Nicardipine and clevidipine inhibit calcium influx into the vascular smooth muscle cells by blocking the calcium channel. Release of intracellular calcium does not occur, which prevents activation of muscle fibers. Thus, vascular smooth muscle contraction is inhibited, causing vasodilation. The dihydropyridines are selective for vascular smooth muscle over myocardium, with little effect on heart rate and no effect on myocardial contractility. Nicardipine is an arterial-specific dilator and does not produce venodilation. Its use is in hypertensive emergencies and is contraindicated in severe advanced aortic stenosis. We can start nicardipine at a dose of 5 mg per hour, then may increase by 2.5 mg per hour increments every 15 minutes to a maximum dose of 15 mg per hour. Blood pressure usually falls within 5 to 10 minutes. It's metabolized by the liver with a half-life of 45 minutes. Side effects may include hypotension, headache, nausea, vomiting, and tachycardia. Of note is that it may be beneficial in patients with acute cerebral hemorrhage. It crosses the blood-brain barrier and causes a localized vasodilation of cerebrovascular smooth muscle with a decrease in vasospasm. Nicardipine dilates small resistance arterioles in the brain, thereby decreasing cerebral perfusion pressure without causing significant changes in intracranial volume or intracranial pressure. Nicardipine is available generically at a cost of about $16 per vial. Another calcium channel blocker drip that we can use is clevidipine. Clevidipine is a dihydropyridine calcium channel blocker similar to nicardipine. It has the same mechanism of action as nicardipine. Its use is in hypertensive emergencies. It's contraindicated in severe aortic stenosis and in patients with allergies to soybeans, soy products, eggs, or egg products. It can be given centrally or peripherally. The dosage is started at 1 to 2 mg per hour. We can double the dose at short 90-second intervals initially. As the blood pressure approaches goal, we can increase the dose by using lower dose increases and lengthening the time interval to every 5 to 10 minutes. The onset of clevidipine is pretty fast, 2 to 4 minutes, with a duration of 5 to 15 minutes and a half-life of 1 minute. The drug is hydrolyzed by esterases in the blood and tissues to form inactive metabolites. Most patients will be maintained at 4 to 6 mg per hour, with a maximum dose of 16 mg per hour and limited experience with doses of 32 mg per hour. In general, the duration should be limited to 72 hours. Side effects of clevidipine can include headache, nausea, vomiting, hypotension, and reflex tachycardia. It's available in two sizes, 50 ml and 100 ml vials, that need to be refrigerated. It's available as an emulsion with a milky white color. Discard the unused portion 12 hours after you puncture the stopper due to infection concerns of the emulsion. The lipid content provides about 2 calories per ml, and lipid load concerns occur at a rate of 21 mg per hour and should be limited to 24 hours if you're using this dose. The cost of the medication is about $70 per 50 ml and $140 for a 100 ml vial. Now let's switch gears and discuss a case of a patient with acute heart failure. CH is a 73-year-old male who presents to the emergency department with increasing shortness of breath over the past few days. The patient has a 3-year history of heart failure. He becomes easily fatigued and experiences dyspnea on exertion with mild exercise. His most recent ejection fraction was 25%. The patient describes having recently experienced increased episodes of paroxysmal nocturnal dyspnea. His past medical history includes hypertension, coronary artery disease, a myocardial infarction 4 years ago, and hyperlipidemia. Medications include metoprolol 50 mg twice a day, lisinopril 10 mg daily, furosemide 40 mg twice a day, aspirin 81 mg daily, and atorvastatin 40 mg at bedtime. His vital signs show a blood pressure of 134/87, a heart rate of 100, respiratory rate of 24, and O2 sat of 92% on room air. His physical examination revealed jugular venous distension of 10 centimeters, bilateral rales and wheezes, hepatomegaly, and bilateral 3+ pitting edema. Chest X-ray shows pulmonary congestion. Laboratories were non-remarkable with the exception of a BNP of 2400 picograms per ml. The assessment of the patient is that he has acute exacerbation of heart failure. The plan is to admit CH to CCU, administer furosemide 40 mg IV times 1 dose, and start nitroglycerin drip and titrate per protocol to reduce symptoms of congestion. Hold for any side effects. Nitroglycerin is a direct nitric oxide-mediated smooth muscle relaxant. Nitroglycerin is metabolized by mitochondrial aldehyde dehydrogenase, MALDH, in smooth muscle and other cells. This results in the release of nitrite ion, which is then converted to nitric oxide. Nitric oxide activates guanylate cyclase to generate cyclic GMP. Cyclic GMP facilitates calcium sequestration and removal from the cell, resulting in vascular smooth muscle relaxation and vasodilation. Nitroglycerin is mainly a venous dilator. It's an arterial dilator only at high doses, greater than 100 to 150 micrograms per minute. It's also a coronary artery vasodilator for angina. Its use is in heart failure. It decreases the preload and increases the cardiac output and decreases oxygen demand of the heart. We can start nitroglycerin at a dose of 5 to 10 mics per minute, then increase in increments of 5 micrograms per minute every 5 to 10 minutes. It has a rapid response of 2 to 5 minutes, and it's short-acting with a 3 to 5 minute duration, and a half-life of 2 to 4 minutes. The maximum dose of nitroglycerin is 300 micrograms per minute. Monitor the blood pressure and hemodynamics closely. Nitroglycerin should only be manufactured in glass bottles because it binds to soft plastics. Some important side effects of nitroglycerin include headache, facial flushing, orthostatic hypotension, tolerance or loss of effect, and methemoglobinemia. One important drug interaction of nitroglycerin is with PDE5 inhibitors such as sildenafil. Excessive hypotension risks if taken concurrently with nitroglycerin products, for example, sildenafil for pulmonary hypertension and isosorbide dinitrate or Iserdil. The case continues. CH initially received a 40 mg dose of IV furosemide on admission with no improvement in symptoms. He then received an 80 mg IV dose of furosemide overnight with only minimal response. Nitroglycerin was titrated up to 40 micrograms per minute, but needed to be held at midnight due to the patient developing a severe headache. Within the last 24 hours, his serum creatinine has increased from 1.3 to 1.8. The patient's chest X-ray shows only marginal improvement in pulmonary congestion. This morning, the decision is made to start dobutamine drip at 2.5 micrograms per kilogram per minute. Inotropes can be used in acute heart failure if the patient is not responding to diuretics and nitroglycerin, but they should be used with caution because they can increase the myocardial oxygen demand of the heart and may cause damage. If used, inotropes should be used at the lowest dose needed and at the shortest duration. Both dobutamine and milrinone can cause vasodilation, so use caution if the patient has low blood pressure. Dobutamine is a direct beta-1 and beta-2 agonist. It's a potent inotrope that will increase cardiac output due to beta-1 effects, and it's a modest vasodilator due to its beta-2 agonist effects. So due to the action on beta-2 receptors, we get systemic vasodilation and a decrease in the afterload. There's no action on alpha receptors, so there's no vasoconstriction. Dobutamine's use is primarily for heart failure. If a patient has been previously on beta blockers, dobutamine's effects may be stunted. The dose range of dobutamine is between 5 to 20 micrograms per kilogram per minute. It has a short half-life of 2 minutes, with a rapid onset of action and quick dose escalation. Dobutamine is a stronger inotrope than dopamine is. Arrhythmias can occur, but less tachycardia occurs than dopamine. Hypotension and tachycardia can occur with dobutamine doses greater than 20 micrograms per kilogram per minute. Milrinone is a phosphodiesterase PDE type 3 inhibitor. So let's take a look at how milrinone works. Let's take another look at the nitric oxide pathway and modify it to help us describe the mechanism of action of milrinone. Cyclic GMP is metabolized by phosphodiesterase to GMP. Milrinone is a phosphodiesterase inhibitor, and when this enzyme is blocked, we get an increase in cyclic GMP and eventual increase in vasodilation. Milrinone is predominantly a vasodilator. It's a greater vasodilator than dobutamine is, but it's a weaker inotrope than dobutamine. Its mechanism of inotropic effect is that it inhibits phosphodiesterase metabolism of cyclic AMP. An increase in cyclic AMP increases calcium uptake, resulting in myocardial contractility. The dose of milrinone starts off as a loading dose of 50 micrograms per kilogram over 10 minutes. Then, the continuous infusion of 0.375 to 0.75 micrograms per kilogram per minute will follow. Without a bolus, we see the effects in 30 minutes. The half-life is 2.3 hours. We need to reduce the dose of milrinone in renal failure due to decreased elimination. Side effects of milrinone can include hypotension, and its prolonged effects may persist longer than dobutamine due to its longer half-life. Arrhythmias can occur with milrinone. It's comparable to dobutamine. And thrombocytopenia can occur rarely. Since milrinone works via a non-adrenergic pathway, it may be beneficial to use in patients who have been taking beta blockers. Here are some key take-home points from this lecture. The calcium channel blockers nicardipine and clevidipine are highly effective IV drips that can quickly lower arterial blood pressure. Clevidipine offers faster onset and titration, but it is more expensive than nicardipine. Both drugs are beneficial in reducing blood pressure in hemorrhagic stroke without significantly changing intracranial pressure or intracranial volume. Nitroprusside is also an effective IV drip that can quickly lower blood pressure. It dilates both the arterial and venous circulation. It's easily titratable as the onset and offset is in seconds. However, one drawback to its use is the release of cyanide and accumulation of thiocyanate in renal insufficiency. Nitroglycerin strictly acts as a venodilator to reduce preload. It is used in acute heart failure to unload the heart to improve cardiac performance. Headache, facial flushing, and orthostatic hypotension are some key side effects. Because they increase myocardial oxygen consumption, inotropes such as dobutamine and milrinone should only be used in cases of acute heart failure that are refractory to diuretics and nitroglycerin. Dobutamine is a pure beta-1 and beta-2 agonist that will increase cardiac output through its inotropic effect and decrease afterload through its beta-2 mediated vasodilation. Milrinone, a phosphodiesterase inhibitor, is more of a vasodilator and less of an inotrope than dobutamine is. We've got a lot in store at the PharmEasy Tutor channel. There will be upcoming talks on pharmacokinetic dosing, treatment of multi-drug resistant organisms, TPN, electrolyte management, cold blue emergencies, management of acute heart failure, and much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.